Thank you so much, Margie and Steve. I realized I failed to introduce myself when I got up the first time. I feel like I know every one of you in the community, but you probably don't know me. I'm Trish Young-Brown, and I'm the president and CEO of Central Health, and I get to work with our board of managers to accomplish all the great and wonderful objectives we have for Central Health as a key asset for our community. I get the, and by the way, Steve and Margie, thank you. I think the presentation was really wonderful in terms of the conversations that are to come. We have our keynote speaker, Dr. Sanchez, who's going to talk a bit about his vision for health in our communities. And our panel will be addressing some of these really key and salient points. I get the honor this morning of introducing Dr. Eduardo Sanchez, who, in addition to being a very dear friend and colleague to many of us in this audience, is the Vice President, and Chief Medical Officer for Blue Cross and Blue Shield of Texas. Many of you may know that we all have spent many years with Dr. Sanchez here in Central Texas, where he practiced as a family physician. He served as the medical director for Austin-Travis County Public Health Department, and he also served as a commissioner for the Texas Department of State Health Services. He is an inspiring and visionary speaker. I think I've had the privilege actually of hearing him speak. This is going to be twice this week. He was at a conference on Monday with the Texas Health Association Health Law Conference, and he speaks very eloquently on the matter of health in the community and how we get there, because I think that's really what's before us. We have a solid community foundation. We have healthcare infrastructure. We have community collaboratives. We have a very, very connected community. And I think what we have before us is the opportunity to move in a direction, come up with a collective vision, and work on this in a very methodical and focused manner. And I think that Dr. Sanchez will be able to give us some ideas about how to do that. So thank you for being here with us today.
It's such a treat to be here, and so great to see so many friends. And I applaud the work that you're doing. Trish talked about my vision. I want to suggest to you this is a vision. This is information that I've put together, thoughts that I've had, but I share them with you. And I think you're going to find it rather amazing and maybe not so amazing that there is a tremendous amount of overlap between some of what you're going to see and some of what you've already heard. And I think it says when you talk to lots of people and you look at what's out there, the collective wisdom takes you down a certain path that Central Texas seems to be taking. There's two people that I want to acknowledge because I think that every one of us is where we are because of people who have had a role in our lives as we go along. And there's so many people here. I don't want you to feel slighted if I don't mention you, but one of them is somebody who touched my life indirectly long before I moved here, and that would be Dr. Charles Mullins, who I went to medical school with, his son and daughter-in-law, two people who are exemplary medical students, and once I met Dr. Mullins, I figured out why, and he's somebody who, from afar, has been a mentor. And another person who's here who was somebody who very, very early in my role as Austin-Travis County Health and Human Services Health Authority played a role in challenging the way I thought about health issues is Ms. Rose Lancaster, who you all know has been fighting the fight and has been an activist for health in this community for a very, very long time. And she and a group of her friends would sit me down, and they never said, "Look, young man," but that was the sentiment. And but it was done in a positively matriarchal way. It was about teaching me the path. I have two title pages, and my administrative assistant thought that was a little weird, but it's because I was given a title, and then I thought about a different way of thinking of this. One was Optimizing Health in Central Texas, really more than a medical system issue. And if I don't leave saying this 5 times, I'm going to say it 5 times. Medical care is really, really, really important when you need it. And medical care is really, really important at different phases of our life. But we live our lives outside of the medical care delivery system. And what Central Texas has to figure out is how to make it possible for people to, everything they do, be about contributing to their health positively, and that all the sectors that make up this area be sectors that do the things that make it possible for people to do the healthy things that will keep them from needing that medical care until or unless it's absolutely necessary. And we want that system to work well when it's there. And so that made me think about a different title, and that's the notion of an accountable health organization. And Steve and Margie mentioned accountable care organizations, and I'm someone who believes that as long as we keep focusing on the care part, which is transactional, it's about the doctor and the specialty referral, and we don't start focusing on the health part, and that's about what neighborhoods are like, and that's about what happens in the workplace and in schools, we're still going to be focusing on the bottom of the cliff and not the top of the cliff. So what we're facing, not only as a nation but as a region, poor health, and while Central Texas enjoys good health, you've already heard that some variation. I'm going to talk about that a little bit more. High medical care costs, and Central Texas is not immune from those high medical care costs. And competitiveness is slipping globally for our nation, and it might be at risk for this area for the very reasons that were already spelled out by Steve and Margie. It's a very competitive job growth environment right now, and so every little advantage makes a difference. And a healthy community with healthy infrastructure, as Pete pointed out, can be the difference. You've heard about this a little bit, but every single one of the 5 counties represented, I promise you the top 5, 6 causes of death are the same. Heart disease is at the top, cancer's number 2, stroke's number 3, chronic lower respiratory disease, which is the equivalent of emphysema and asthma, is number 4, and diabetes is number 6. And I always point out diabetes because although it seems like it's at the bottom of the list, what kills people with diabetes is cardiovascular disease. So if you're only looking at death, you can understate the role that diabetes plays. Now, a different way of looking at this is not what kills us, but what ails us. And so I came across just very recently a list of the 10 most costly conditions for men and women, and I've got it broken out that way. But I want you to see that there's some things on that list that you didn't see on the mortality list. There's heart disease and cancer, because they not only kill, but people live with them. Some people are cured of them, but not at insignificant cost. Mental disorders is up there, and that was mentioned by Kirk Watson. That's really important because although it doesn't kill, it certainly reduces life expectancy by over 25 years, people with severe mental illness. Trauma-related, osteoarthritis, and I'm getting to that point in my life now where my joints hurt more than they used to, and we all know people whose joints hurt. Doesn't kill them, but it sure makes life unpleasant, and it's a cost driver. There's COPD and asthma, and there we go, and there's back problems. There's diabetes, but again, diabetes lives with hypertension, it lives with heart disease, and it lives with hyperlipidemia, which is elevated cholesterol. Diabetes doesn't like to travel by itself, so diabetes is a very, very expensive condition, and for men, the list is a little bit similar. The one difference is that for men, trauma-related costs are higher than for women. So here's another truth, and that is that the cost of medical care increases as we age. Now, it's high on the front end, and that's a good thing because we should be taking our children to get immunizations and get those well-child checks. And in the first 2 years of life, you see a doctor more times in the first 2 years of life than you're likely to see a doctor for the next 6 or 7 years of life. But that's a good thing. Those are times where you really want some surveillance going on, some monitoring going on. And then the costs sort of stabilize until you hit about 50 years old as a population, and then the costs start going up. And if a population is aging, and some of our counties are aging more than other counties, those medical care costs start creeping upwards. We talked a little bit about why we have things that kill us and why we have things that ail us. And this is a list. You may have seen a variation on this, but it has to do with lifestyle issues, dietary issues, and some metabolic risk factors that aren't necessarily being taken care of. Smoking is at the top of the list. So if there's enough people here from other counties, if I leave and don't say this, I would feel really, really badly. Pass an indoor smoking law in your counties. Pass an indoor smoking law in your counties. We need to pass one in the state of Texas. We haven't done it. You've probably seen the commercial with the elephant in the room for Spiriva, and in that commercial they let you know that COPD is not reversible. Well, you know what? COPD is completely preventable, and they ought to be telling us that. If we didn't smoke and we could figure out ways to keep people from smoking, we could go a long way to make a difference. If that was all we had to do, I could sit down and we'd be done. But the list continues. So there's high blood pressure. Why is that there? That's because although we do a really good job of measuring blood pressure and knowing that people's blood pressure is high, only 50% of people whose blood pressure is high have their blood pressure controlled. And blood pressure is just basically a time bomb. It's a time bomb for stroke or a time bomb for heart attacks. And that we don't have people's blood pressure controlled is a travesty. Thing is, as we look at income and we look at insurance status, that's going to predict whether someone's blood pressure is controlled or not, more than a lot of other factors. And then the rest of the list are things having to do with physical inactivity, weighing too much, high blood sugar, and then a whole host of dietary factors that are really, really important to note. Now, here's something else that came up, and I think it's important to point out, and that is that excess mortality, oftentimes we just sort of boil it down to what was the disease that killed that person. And this was a study that was just done and came out in the August issue of the American Journal of Public Health that says, you know, there are some other factors that can predictably lead to premature or excess death. And there's your list: low education level, racial segregation, low social support, individual poverty, income inequality, area level poverty. And as one looks at, and I'm going to show you in a moment, the comparisons of the 5 counties, and all I've got is county level information. If you look within counties, you're going to find places where these things are more true for some people than for other people. And as we think, and as y'all think about the notion of health for Central Texas, thinking about these issues is really, really important. So one thing to say, health equals productivity, which equals prosperity. And that's an important equation because as we go along, there are short-term and long-term ways of dealing with this. Educating our young people is one of the intermediate to long-term ways of dealing with this issue. But we've got a ways to go in terms of education. And here's one other thing that maybe wasn't talked about. Steve pointed out that the likelihood of getting diabetes is related to your educational attainment. But we're not graduating from high school at equal rates. And in a community like, in an area like Central Texas, where Latinos are becoming, are going to emerge as a majority population, when we're not graduating our young people at the rates that we are graduating others, that portends a future that is one that fortunately can be changed. And I do know that there's efforts being made in all of our counties and in all of our school districts to reverse this situation, or to equalize, raise the graduation levels, because when you multiply the likelihood of getting diabetes with this, you are talking about a challenging situation going forward. You've seen this graph in a minute. The prevalence of diabetes varies by race, ethnicity. So if you're Latino, 11% in Texas have diabetes. African Americans, it's closer to 13%. For whites, it's 8%. As the population shifts, as Steve pointed out in a different version of this same graph, you see that for Latinos, the prevalence of diabetes is going to increase. And for our state, and maybe not quite a doubling in the 5-county area here in Central Texas, but we're going to see an incredible burden just of diabetes alone. And that burden is a burden that will do a few things. One, resources have to be spent to treat and manage diabetes. It's treatable, it's manageable, but I like to say I'd rather prevent a case of diabetes than to have to treat one really, really well. And that's the challenge, and how do we go about doing that? Preventing diabetes is a non-clinical premise. That is about eating healthy, being physically active, being connected, doing things that all the prescriptions in the world that doctors write are not going to result in people going to Walgreens and picking up their physical activity pill. People are going to have to do some things, and in order to do those things, business communities, schools have to change some of what's going on. The work site has to be a place where people can move their bodies and know that there's healthy options to eat. Schools have to continue to be places where physical activity becomes more and more of a daily thing, as it used to be at one time, and not so much a every other day thing. Interestingly, we know that fit kids are smart kids. We know that kids who are active, particularly boys, behave better in the classroom. There's all kinds of great reasons why children should be more active in the classroom than they are now. So I'm not going to go through the next 5 slides because that information is there for you you can go to the Mobilizing Action Toward Community Health or look at community health rankings. I saw that they were referenced by Steve and Margie, but here's how the counties line up compared to the 254 other counties in the state. And you can see that Williamson County has the best health outcomes in the state, and that Bastrop actually does pretty well when you think about 254 counties. But let me be clear, there's a couple of things that I want to leave you with. You heard that we are 24th in terms of healthy lives in Texas, and we're 49 or 48 or 51 on everything else. Don't be fooled. That healthy lives is about a younger population. It is not about a healthier population. It's all based on the fact that we have a relatively youthful population that is on the path, if we don't change things statewide and maybe follow the example of Central Health, to being 50th in healthy lives as well. And in these health factors and health outcomes, I think the key thing to let you know is that within every one of those counties, there are pockets that are not as healthy as maybe those factors would suggest. And that although Williamson County is very healthy, within Williamson County there are folks who could use a different way of thinking about health. Pete can tell us all about that. That's true in Travis County as well. For an urban city, for an urban center, Travis County and Austin are doing extremely well. But those of us who, and I was a board manager for Central Health, we know that there are pockets within Austin, Texas, within Round Rock, Texas, down in Hayes County, where there are folks who look and act and live and have circumstances that look very much like the things we describe as being border county kind of issues. We can't forget that. We must be mindful of that. We've got to raise health status overall. Now, there are statistics for every single one of the counties, and there's way more than what I put on this graph. This is all that I could fit with my limited PowerPoint editing capacity and capability. But there's some key ones that you might want to look at, and these are all things that were touched on. So in your spare time, you can look at this while you're looking at the white paper. But there's one of these for every single one of the 5 counties. There's actually one of these for every county. I'm pushing and nothing's happening. So one of the things that I would ask that you think about, and I think I've gotten there, is that place matters. Well, here's just an interesting factoid. People living in low-income communities, 80% more likely to be hospitalized for diabetes or related complications. And what that means is that as we're taking care of people in the medical care system, we need to understand the context of their lives. Just writing a prescription and saying, you know, live long and prosper, and discharging people, not enough. You got to know that you may be discharging them to 78702, and that's a very, very different thing than 78703. And for those of you who don't know, I think 78702 is East Austin, 78703 is Terrytown, and those are just 2 very different places. And what's around you and the resources you might have and the connectedness, all the things that are about your life outside the clinical setting will make a big difference in how it is that you go about dealing with that issue of having been hospitalized or having a chronic disease. Here's another thing we hear a lot about. Personal responsibility. And I just ask you to think about, is it personal responsibility or is it an issue of healthy food accessibility? And Steve talked about food deserts and food swamps. So I don't want to go through all of this too much, but low-income areas have 1/3 fewer grocery stores than higher-income neighborhoods. So when I was a doc, oh, and I do want to tell you, I know the doctor who told the story about the person with the blister very, very, very well. And what I would say to you is that person, that individual was lucky that he was in Travis County and not in Hudspeth County, where the outcome may have been very, very, very different. He was in a place where there is some infrastructure in place, and I think it reminds us that having that infrastructure in place can make a difference even for the uninsured in some of our communities. But the point of that is that 1/3 fewer grocery stores in higher income neighborhoods means that if I'm writing a prescription for my patient with diabetes or talking to them and I say you need to eat healthier and here's what you need to do to eat healthier, and the issue of getting to the store is a problem, and the issue of buying the things that we think they need to buy is a problem, we need to think beyond just the counseling and think about the context in which people live. So what we know: a healthy workforce equals higher productivity and lower medical costs. And frankly, a healthy population equals better parents. Believe me, they have less things to worry about. And better parents, we know, mean that our children are growing up in caring, nurtured, positively stimulating environments where they are more likely to succeed in school. Fit kids equals smart kids, and higher educational attainment equals better health, higher income, and a higher likelihood of health insurance. Now, you heard about this already, but I love this tip of the iceberg slide. Medical and pharmacy costs, when we think about poor health status and employee, represent 25% of the action. 75% of the costs are actually productivity costs. Absenteeism, and presenteeism. And why that's important is corporate Central Texas, those of you who are here and maybe think of health as a cost related to what you pay for the premiums or for the health plan that you are a part of, it's more than that. It is about what is fundamentally happening or not happening in your place of business. And so there's a vested interest that corporate Central Texas should have in achieving optimal health, because that optimal health equates to higher productivity as well as, or in addition to, lower medical care costs. I love to read this. I think of it as the Dr. Seuss for grown-ups. The healthcare system is an expensive plethora of uncoordinated, unlinked, economically segregated, operationally limited microsystems, each performing in ways that too often lead to suboptimal performance. Pretty good, huh? All in one breath. It reminds me a little bit of Sam I Am, Green Eggs and Ham. What we need is a system. And it's a system that employers are demanding, and appropriately so. We need a system that ensures optimal health for all, has high-quality medical care when necessary, because that system has to be more than just the medical care piece. It's got to be what's happening in the workplace. It's got to be about what happens in communities. It's got to be about what happens in faith communities. It's got to be about what happens in schools. It's got to have a reasonable cost, and that reasonableness is just kind of going away. We have better and better and better technology. And one of the curious things is that while in the consumer space, whether it's computers or televisions, there's always kind of price pressure down. In the durable medical equipment world, it's the other way around. Everything costs more, and it stays costing more. You don't see quite the reductions. Management, wellness, prevention, disease management. And then they're demanding analytical capacity. I saw one of my friends shaking his head at something I said, and it may just be that we need better tools to be able to make some of the statements that we make and support it with evidence. Sometimes I don't do that. PricewaterhouseCoopers says, same thing. Employers want better information. They want data turned into actionable information. And that doesn't, and the good news is, some say, this is no different when we talk about ACOs. That's no different than talking about HMOs. The truth is the difference is we do have this information technology capacity that we didn't have 30 years ago. And the truth is, to Margie's point, that our mobile communication tools, while they can't beam you up to the Starship Enterprise, they can motivate you to eat healthier or to move your body or to take your medication. And we're all beginning to realize that even these lessons about the medical care community is not where it all happens. Technology is very pervasive and can be used to penetrate those non-clinical spaces. There is a national strategy for quality improvement in healthcare. That's a good thing. It's a blueprint for how we need to get where we want to get. It's a blueprint that Central Texas can use to think about how it gets there, and it has 3 pillars. I personally think the middle pillar is the most important one: healthy people, healthy communities. But the other 2 pillars, and here's the point about the healthy people, healthy communities, third line: address behavioral, social, and environmental determinants of health in addition to deliver higher quality care. In other words, an acknowledgement that there are non-clinical aspects to getting to where we need to get. Better care and affordable care, absolutely necessary, but not sufficient. New England Journal of Medicine. Go to the 3rd bullet. We need a mix of evidence-based environmental, regulatory, and behavioral interventions at the population and individual levels. So here's something that I will tell you. I am the chair of something called the National Commission of Prevention Priorities. We know that immunizations are really important and that they work. We know that childhood immunizations are a cost-saving intervention. What we sometimes struggle with is getting the horse to the water and the horse to drink the water. And so there are strategies. So it's a given that when the patient is in the room and the vaccine record is not up to date, let's take care of business. What's challenging sometimes is getting that individual to the place where that vaccine is going to be delivered. We know that there are strategies that we can employ and deploy in communities that will mobilize folks. And so it's a combination of community efforts and clinical efforts, even to drive people to those clinical solutions that we know will make a difference. And here's a graphic that captures that. It's the chronic care model that says it's more than just the health system. Community is part of it. Informed, activated individuals are people who are going to act in their best behalf to be healthy and do the things that will keep them healthy. And some things involve seeing a doctor. I don't want to make jokes about pap smears, mammograms, and colonoscopy, but you need someone else to do that. Eating healthy, being physically active, maintaining a healthy weight, avoiding tobacco. Help is good, but you don't have to have that other person or that other system to get it done. These cancer prevention things, absolutely. Healthy people do healthy things. They eat smart, they're physically active, they maintain a healthy weight, and they avoid tobacco. But what it takes for people to be healthy is a community that can help activate those things. Healthy communities have the elements that enable health. Accessible, affordable food, you've heard about it. Accessible, affordable venues for activity. That's just a fancy way of saying places where people could go move their bodies. Safe, healthy, academically strong schools. Wellness-supporting workplaces. Accessible, affordable primary care. Notice, I didn't put that at the top of the list because all those other things are vital for our health, as is primary care. But without primary care, you still have to do all the other things and still can do all the other things to stay healthy. And access to public health services. I'm going to try to close on 2 things This is an interesting slide that says when you spend money on public health services, mortality rates go down in a variety of categories. It's important to note that. But I want to go to this, and I'm going to close with this, because I think it's a way to say this is where Central Texas can differentiate itself. You may remember that The Cost Conundrum was an article written by Atul Gawande in June 2009 that really kind of reactivated the whole health reform discussion going on nationally. And what it pointed out is that for Medicare enrollees, the cost of services in McAllen, Texas was 2 times what it was in El Paso, Texas. This huge, huge variability. And we asked ourselves in Blue Cross Blue Shield, is that the same for people who have Blue Cross Blue Shield insurance? It turns out it's not. It's almost equal. They suggested that compared to El Paso, McAllen had a lower education level, lower per capita income, more poverty, and a higher immigrant population, all factors that I think probably contribute. But there's a few other things that are different between McAllen, Texas, and El Paso, and are actually more similar about El Paso and Austin that I think make a difference. One, El Paso has a full-service health department compared to McAllen, Texas. I believe that may have been a contributor. 2, McAllen has a full-service hospital district, not unlike Central Health. I believe that made a difference. El Paso has a foundation, Paso del Norte Health Foundation, which is a conversion foundation. I'm on the board, full disclosure, that invests $10 million a year, can't get that word out, $10 million a year in health on the upstream part of improving health. That's about $10 per capita. That is enough. You saw $5.61 can make a difference. That's enough to make a difference. And it's got a medical school now, and that makes a difference. So let's compare El Paso, Texas to Austin, Texas, and just suggest to you there's a way for you to harness what you have to take it to the next level, engage the community. 1, Central Health is here. 2, there is a full-service health department in Austin, Travis County that can work even more collaboratively with some of the other health departments, and there is a regional health department that the state runs that helps bridge things together. There's opportunity there. 3, you're talking about it, enhancing the academic presence here, and that can only make things better in that regard as long as it's connected to all these other points. And 4, the St. David's Healthcare Partnership, Michael and Susan Dell Foundation are here that can lend support to some of this work. So I believe that you are in a great position to move from vision to reality. And I think this first discussion that brings the business community, in addition to others that are already working in this health space, to begin thinking about Central Texas health in a different way to a new place in very short order and serve as a beacon to the rest of the state and the rest of the nation on how one can get it done with a can-do attitude. So I thank you so much for allowing me to be a part of this, and it's so good to be back at a place that I still can't help but consider home. So thank you very much. I believe that it is now my distinct honor and pleasure to introduce Bill Sage. I first met Bill Sage in 2005 in Galveston, Texas at a health policy gathering that Ken Shine had a hand in orchestrating, and I'm beginning to believe that Ken Shine is the new Kevin Bacon. Everyone is like 1 or 2 degrees of separation away from Ken Shine. Bill Sage, those of you who know him, might agree with my first impression. A really smart guy, I thought, but he's just a visiting academic from the Northeast. He's still a really smart guy. He's an activist for health in Austin and all of Central Texas. He's an academic based in UT who is a contributing thought leader in health policy nationally. We've been friends since he saw the light and moved himself from up there to down here. So it is a privilege for me to introduce Dr. Lawyer Bill Sage, my friend and colleague. He's got lots of degrees. affiliations and accomplishments, and you can read about those probably if you Google his name. But he is an authority on health law and policy and serves as Vice Provost for Health Affairs and the James R. Doherty Chair for Faculty Excellence at the University of Texas at Austin. We're fortunate to have him with us this morning, not only to inspire our thinking about health in Central Texas, but about new ways of thinking about healthcare and health. Bill and I are kids at heart and real cheapskates to boot. And several summers ago, we found ourselves together at a childhood obesity summit in Little Rock, Arkansas, that included a visit to the Bill Clinton Presidential Library and Museum. For several years, he and I have had matching Bill Clinton Museum watches. They were really cheap, and that's the cheapskate in us. And for a while, too long probably, the word Shazam was was our own shorthand about that particular day. So without any further ado, Shazam, Bill Sage.